Welcome to the Resus Room podcast.
5, 4, 3, 2, 1, fire!
So hi, and welcome back to the Resus Room podcast. I'm Simon Lang.
I'm Rob Fenwick.
And I'm James Yates.
And we're back with another Roadside to Resus on seizures.
Yep, just another tiny topic to start us off for the year then.
It'll be brilliant. There weren't too many difficult questions on Twitter either, so I think this is going to be fine.
There was some in-depth stuff there, so I hope you're picking up on all the complicated stuff, James. Excellent.
Yeah.
I must say, we're showing a high degree of dedication to this. Not only is the final of The Apprentice on whilst we're recording, but also I'm struggling with my voice following our Christmas night out last night.
I'm sure you're only invited to provide the entertainment anyway, Simon, your singing voice.
It's nice of you to think that I was invited.
Were you the plus one for your other half?
You can always get into these events if you try hard enough.
Anyway, let's get cracking with this.
Okay, well, before we get into it, a huge thanks to SJ Trem, the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine. They're our partners in crime with this podcast, and they make it all possible. Go over and have a look at their website and all of the free open access articles on the sorts of topics we cover here on the podcast. So without further ado, let's crack on with the episode.
All right then, team. So what are we actually going to be talking about on this episode? Well, a seizure. Let's start off with a definition, as we always do. So it's a paroxysmal electrical discharge of the neurons in the brain, resulting in a change of function or behaviour. Now, that definition is pretty important because that seizure that we've just described is actually a CNS event or a central nervous system event. And there are some other things which can mimic seizures that we'll be talking about later on. Now, from a CNS perspective, these can present, unfortunately, as both convulsive and non-convulsive, and don't worry, we'll be going over this in a little bit more depth. But the main chunk of what we're going to be talking about today is epilepsy, and specifically its meaner, bigger, more horrendous sounding older sibling, status epilepticus, which it does make it sound a little bit like a comic baddie, doesn't it? That's right. Yeah. What's that over there? It's status epilepticus. Everyone run away. So epilepsy is a common neurological disorder which anyone who works in emergency care will be familiar with. I'm familiar with the seizure-related elements to it. And it's been described for well over 2,000 years. So right back in the historical archives, there were descriptions of epilepsy. I'm sure Simon will be referencing some of that when he comes to his bit later, but me and James will try and keep it a bit more contemporary with regard to that literature. So in terms of a bit of background to epilepsy in general, so the estimates of incidence and prevalence are really, really difficult to accurately achieve because there's several different reasons, but the first thing is identification of people who have epilepsy is difficult. The second point is that nearly 80% of those people live in low and middle income countries, and in many parts of the world it's stigmatized, and therefore people don't seek treatment, and we don't get an accurate reflection of how much of a health related burden this condition actually is. So in the UK, there's approximately 500,000 people. So this is 1 in 100 people. And worldwide, this would equate to roughly 65 million people living with this condition. So this is a massive problem that we need to be on point with.
That's a lot.
Oof.
Indeed, it is, yeah. So, interestingly, when you read into the literature, there are approximately in the UK, and this is really surprising, over 125,000 people who have or are thought to have an incorrect diagnosis of epilepsy. So, receive treatment, receive medication, but don't actually have the condition. And this, when we come on to treatment and thinking about further testing, is really important as well, because we don't want those patients being misdiagnosed. We want to get the right diagnosis and treatment for them.
I'd never have thought you'd be able to see that many patients, Rob, to misdiagnose them.
I'm not. That might be my lifetime patient count. I don't know. But a little bit just about epilepsy. So it's got a bimodal distribution in terms of its age. So it usually starts, and it's the same with status epilepticus, which we'll talk about later. But it's either in childhood or infancy, and then in people over 60. So you have this big peak in childhood and a big peak over 60s. So those are the two classical groups. You don't tend to get that many diagnosed in sort of the middle part of their life. And it's a lifelong condition, but 2/3 of people have it really well controlled with anti-epileptic drugs. But but 1/3 do remain resistant to medical management, and I'm sure many of us will have seen those coming through our emergency departments and through our services. So as we said earlier, seizures can occur for a multitude of reasons, one of those being epilepsy, which we're going to discuss shortly. But the majority of what we'll be on about is these CNS causes. So Simon, I know you're up on your CNS causes of seizures. Can you run us through a couple that you might have encountered in your vast experience?
Yeah, well, I think that's a bit hyperinflated, but
I was setting you up on a pedestal, mate. Soak it up. It's nearly Christmas.
This feels very uncomfortable. Yeah, so I think it's really important, isn't it, to appreciate the fact that a seizure is a reflection of something that's going on, and we really need to be aware when we're seeing patients and we're thinking about the way that we're going to treat them, that we appreciate what the possible underlying causes are of that presentation. So the sorts of things that we need to have running through our mind are things like infections, so meningitis or encephalitis, episodes of hypoxia, so we've all seen people that would have collapsed with a vasovagal episode that would have been held up for a period of time. They get cerebral hypoperfusion, they're hypoxic, then when they're delivered down to the ground in a soft and gentle manner, then the seizure will stop. Vascular events, so things like intracerebral bleeds, metabolic events as well that are going to change the way that neurons are going to discharge, so things like alterations in glycemic states or sodium levels. Things that we can also see are structural, so things like tumours, patients especially in the summertime presenting with hyperthermic seizures, and also a really frequent presentation are drug-induced seizures, so things such as alcohol withdrawal or having ingested other things such as tricyclics.
Just to add to the end of that list is, of course, eclampsia. So this is a complication of pregnancy which can be present at any point over 20 weeks. So 20 weeks is your cut-off for thinking about that as a potential cause in a female. So the exact mechanisms underlying that are pretty unclear, but we'll talk a little bit about the treatment later. And of course, finally, there's epilepsy, which will be taking up a big chunk of what we're talking about today.
Yeah, so I think that's a really good introduction to the topic because it can be quite confusing. And I think one of the key descriptors and denominators that we need to be aware of is that actually seizures and epilepsy aren't the same thing. And I think you've well described that, guys. So just a quick summary of the fact that a seizure is the sort of the transient occurrence of the signs and symptoms of this sort of abnormal, excessive or synchronous neuronal activity in the brain. Whereas epilepsy is the sort of neurological disorder in which the person experiences the recurring seizures. So I guess every seizure is not epileptic, but epilepsy results in seizures. Everyone clear?
Got it.
Yeah. Brilliant. So we've defined what a seizure is. So I guess we've been alluding to epilepsy a lot. So what is epilepsy? So epilepsy is a disease of the brain that's defined by at least 2 unprovoked seizures occurring more than 24 hours apart. Now, that's the kind of the core definition. There are a couple of other ones that get used sometimes, and that is 1 unprovoked seizure with a probability of further seizures occurring in the next 10 years. But obviously that risk is very difficult to define and is often unknown, and so generally that default diagnosis is referred back to at the beginning. And then the third option is a diagnosis of an epilepsy syndrome. Now, that might sound obvious, but an epilepsy syndrome is slightly different to epilepsy. There's a lot of different age-related epilepsy syndromes which can be outgrown. But generally, it is that 2 unprovoked seizures occurring more than 24 hours apart is the fairly standard definition. So seizures can present differently and in different ways, and we're going to discuss that shortly. But as Rob has said, this episode really is going to focus on seizures and the tonic-clonic variety. So let's have a think about tonic-clonic seizures then. So the vast majority of those seizures are self-limiting and they resolve within about 1 to 2 minutes. And I think anyone who's worked in the pre-hospital setting for any length of time will be aware of that. You know, we get called out to seizures a lot, and actually it's really rare to get to a patient who is still fitting. So I think we're all fairly comfortable with the idea that seizures are generally self-limiting. But the problem comes, and the focus of this podcast really is on what happens next. And status epilepticus, which Rob mentioned earlier on, is a really important term. And that refers to prolonged seizures of any type, so not just epileptic. So what is status epilepticus? Well, traditionally it was defined as convulsive activity for 30 minutes or more. that inherently feels like a really long time, doesn't it?
Ages. Absolutely ages. 30 minutes.
I know.
But that's what I was taught as well when I was a baby clinician, so to speak. Yeah, that was right. 30 minutes.
Yeah, absolutely. Well, you will be pleased to know, and I'm sure sufferers of epilepsy and seizures will be pleased to know that actually the definition of status epilepticus has been changed, and the time frame has been reduced to seizures lasting more than 5 minutes, or more than one seizure within a 5-minute period without sort of returning to a normal level of consciousness between them.
Just to jump in there, it's actually quite interesting if you read into the history of around this 30-minute figure that was used for a long time. And like the precise definition sort of depended a little bit on the context, but historically it was described as being like long enough, or, you know, an enduring episode was like the sort of terms that were bandied about in like the 60s, 70s and 80s. And then there was a few studies done in the 70s on sort of monkeys and on canines that showed that they lost their ability to cerebrally auto-regulate, so cerebrally provide that oxygen after about 30 minutes. So that was where this 30-minute figure came from. So it was almost to the point where in animals, well, they could no longer regulate their cerebral flow and oxygenation. So we'll extrapolate that into humans and we'll say that, you know, at 30 minutes it then becomes serious, whereas at 29 minutes it's okay. So it's pretty good that it's actually changed and we're treating it a little bit more aggressively now.
Really, really good that you were slating me earlier for all my what I was going to bring up from my historical data, and here you dig out some studies from the 70s about some really interesting canine stuff. Great work, Rob.
I think it's important to have some context, Dr. Lang. I think it's important to have some context.
It is important, isn't it? Because when you mention status epilepticus, you suddenly get a heightened concern about how sick that patient is.
Yeah.
And what this does by bringing the definition forward to 5 minutes is that hopefully it means to all of us that when we see someone that's been fitting for 5 minutes, they are sick and we really need to be proactive in our treatment for it.
Yep.
You're absolutely right. And actually that is borne out really by, again, it really is only animal data, but that the animal studies have shown that within 5 minutes that you start to get neuronal injury from seizures. And I guess that's why this change has occurred. It really is to emphasize the seriousness of the condition and the need to treat it urgently. And interestingly, at the 5 minute point, there's an approximately 80% chance that the seizure will then continue on for more than 30 minutes unless we intervene. And that's important because untreated, the mortality associated with convulsive status epilepticus approaches about 30%. So it's really important that we intervene.
With you saying that as well, the modifiable stuff that you can do. So, I mean, the status is affected by various things, but sort of age of patient, underlying condition and duration affects the mortality. And the only thing pre-hospitally and in-hospitally we can do to affect that is the duration, isn't it? Because we can't really at that point treat the reversible cause unless we know it, and we can't affect the age of the patient. So it's really about what we can do from a mortality perspective to improve things, and it is the duration, and that's why it's so important we act aggressively with them.
But the other thing I think to be aware of as well is that all of these studies that you look at, the prevalence of the different causes for that seizure as well are all going to be slightly different. So drawing out hard morbidity and mortality figures when different populations of patients are presenting with different incidents of infections, of structural abnormalities, etc., is quite a challenge, isn't it, to tease out?
So guys, it's probably just worth clarifying at this point in time that the highest mortality rate when thinking about status is associated with those seizures that begin as the generalized tonic-clonic seizures. And I suppose we also should think about why it is that there is a high mortality rate. I guess there's a few different options. One of those is primary neuronal injury from this burst synchronous activity of the neurons in the brain. And then the others are almost like a secondary injury, if you like. Things like hypoxia, respiratory acidosis, dysrhythmias and aspiration pneumonitis, things that occur secondary to the seizure activity. But the good news is, although we've been talking about high mortality rates, if we follow an evidence-based treatment algorithm, then we can significantly improve these patients' outcomes. And that is why, obviously, we're going to focus on tonic-clonic seizures and status epilepticus for pretty much the rest of the episode. Although I think somebody knows a little something about the different forms of seizure that we might come across.
So I think this is useful just to have in a background. And actually, if you're not considering it, there are a lot of presentations that you'll get acutely that will be epileptiform in nature, but actually you may not pick up because they're not the generalised tonic-clonic seizures. So you can split them up into focal or generalised seizures. And what that refers to is the parts of the brain that are affected. So is it just one part of it, or is it both hemispheres in the generalised seizures? Focal seizures can have a retained awareness, or this can actually be lost. And it can spread from being just a focus to both sides into a generalised seizure. And this focal seizure is actually the aura that we talk about before somebody goes on to have a generalised tonic-clonic seizure. Generalised seizures affect, as we said, both hemispheres, and there are some main types that we want to mention. So absent seizures, and these used to be called petit mals, are actually really brief. They last between about 2 and 10 seconds, and there's no postictal confusion after the patient has had a seizure. And they can normally go straight back into what they were doing, so almost like they've just had a bit of a time out. They tend to involve staring or basically not responding to any verbal stimuli, and they sometimes involve head nodding or blinking. On to the seizures that we're really thinking about in this podcast, and these are the tonic-clonic or convulsive seizures, formerly known as grand mal seizures.
Grand mal? Grand mal, that's what it's like in Bristol, James.
Posh in the southwest, mate.
Yeah. In the Midlands, it's called grand mal.
So they usually last 1 to 2 minutes, and that also plays into how we treat them, because if they're likely to self-terminate and you don't need to give them any medication, then that's great. What you see to start with is contraction of the muscles. So this is a global contraction of the patient in the tonic phase, and that's then followed by the clonic phase, which is the rhythmical twitching. It's bilateral and it's symmetrical convulsive movements. And it's important to know these when you're trying to differentiate other presentations that may be seizure mimics. The saliva that the patient's got won't be swallowed, so that can pool at the mouth and there can be some frothing. The respiration might be irregular, and when they've stopped seizing, regaining consciousness happens slowly. And this, as we've referred to already, is the post-ictal period.
So you mentioned around the pooling of saliva around the mouth, but there's some other stuff that we classically think of as being definite, as in, this is 100% going to be an epileptic seizure rather than any other type. What about urinary incontinence and tongue biting?
So those are really interesting ones, because you can pretty much guarantee that somebody will ask the clinician that's seeing the patient whether or not there was either of those two things. And urinary incontinence actually has got no value in differentiating between an epileptic seizure and a non-epileptic event. So don't be falsely swayed one way or the other by whether or not the patient's got urinary incontinence. Tongue biting is an interesting one though, and there are some papers that we've got referenced in the show notes. My overall take on this is that you're probably a bit more likely to have had an epileptic seizure if you've bitten your tongue. But when you're considering the psychogenic presentation that James is going to talk about in a little bit and an epileptic seizure, then actually lateral tongue wall biting is much more likely to be due to an epileptic event. Just skimming through the other generalised seizures that we need to be aware of. So you can get things like atonic seizures, which are also known as drop attacks, where the patient suddenly has an abrupt loss of consciousness and falls to the floor. There's no convulsion, and then after a few seconds they regain consciousness. And myoclonic seizures as well, which is sudden, brief, and also some described as lightning fast movements that aren't associated with an obvious alteration in consciousness. And they can affect one muscle or they can affect several muscles. So therefore they can either be generalised or focal.
Just with you reading through them, it just makes you realise how difficult diagnosis in transient loss of consciousness is, doesn't it? Do you know what I mean? Because there is so much overlap between this and like cardiovascular causes, etc., etc. But yeah, it's a tricky area, isn't it? Particularly for those that aren't having that classic tonic-clonic seizure activity.
And that's why we're going to recommend that every single person that thinks they might have a syncopal event should just walk around with an EEG on all the time.
Are we? I haven't seen that in here, mate. What?
So those are pretty much it. So just to sum up, you've got your focal seizures, which are affecting one part of the brain, or your generalised seizures, which are affecting both. And focal can progress to generalised. There are obviously other seizures as well, such as infantile spasms, such as infantile spasms and psychogenic non-epileptic attacks, which I believe Professor Yates is now going to run through.
Clear the lectern.
Well, pay attention. No, this is really interesting topic, actually, and I have to say, the more I've read about it, it really has opened my eyes, and so I hope to impart some of that wisdom to you all, because it was actually definitely an eye opener for me. And so what we're talking about are these psychogenic non-epileptic attacks. You might also have heard of them as functional seizures, non-epileptic attacks, or pseudo seizures. And you all know what I'm talking about. It's those patients that you turn up to the side of and you look at, and I guess you use your thin slicing, and you're making this very rapid decision about what you're seeing, and something doesn't feel right. It doesn't look like a proper seizure, and you think, they're just faking it. It's a total waste of time. They're putting it on. We'll just get them to snap out of it, which I think are very common. I hope common, otherwise I'll just totally drop myself in it. But I think common thought processes that may be going through your mind. Well, hopefully by the end of this section, I may have dispelled some of those myths for you. Because although they can feel very frustrating to deal with from the clinician's perspective, I think it's really important to realise that these guys aren't faking it. So there's a really great opinion piece from a Yale neurologist called Tolchin that was published in JAMA not so long ago. And I've taken some of that paper and tried to distill down some of the learning points. So this is, I guess, the key element of it all really, is that these non-epileptic attacks are transient episodes of involuntary movements or altered consciousness caused by psychological mechanisms, often involving intense stress. And they're the most common form of functional neurological disorder that's seen. And unlike sort of factitious disorders or malingering, these non-epileptic attacks, they're not consciously produced or controlled by the patient. So it's really vital that we don't think that they're faking it. These are true episodes and true events. The challenge being that these non-epileptic attacks can appear very much like epileptic seizures, but the treatment is extremely different. And anti-seizure medications and longer-term surgeries don't provide any benefit, and I guess importantly can also cause dangerous side effects. So if we administer our first-line anti-epileptic drugs that we're going to talk about in a second to someone who is having these non-epileptic attacks, then actually they've got no benefit and may result in things like respiratory depression, which is not great news. So the words of advice from Tolchin in this paper is that actually the most appropriate ED management of these non-epileptic attacks is really primarily reassurance. So telling patients they're in a safe place, you're going to take care of them, and that you're not going to do anything painful or distressing. I think that the take home really is be kind to these patients. They are not putting it on. This is a real disorder.
I think that's really important, and I think also then once the event has ceased, there then can be some really important things to do with the psychological presentation and things that we may be able to assist with, either sort of at the time of their presentation or at least offering help and advice later on down the line with some specialist services. But those things that you were talking about that give you that gut feeling that it isn't an epileptiform seizure, what are those things that we're realising in those presentations?
So that is a great question, because it is very difficult to tell the difference between the two presentations. And actually, thankfully, we're helped out by a study that was published in the Journal of Neurology, Neurosurgery and Psychiatry in 2010. And this was a review of 34, obviously, observational studies that looked at the associated signs and symptoms that came along with status epilepticus and non-epileptic attacks. And they looked at whether any of them could be discriminatory to try and identify between the two conditions. And thankfully, there's about 6 items that we can try and use to try and differentiate between the two. So first of all, longer duration is really strongly associated with non-epileptic attacks. We've said that actually the vast majority of epileptic seizures are self-terminating within 1 to 2 minutes. And we're then going to come on in a few minutes to talk about first-line anti-epileptic medicines for status epilepticus. And a majority of patients respond to those. So if you have someone who is progressing on beyond sort of 5, 10, 15 minutes, it starts to make you think that this could be a non-epileptic attack. Other stuff that's maybe slightly more subtle, a fluctuating course of the seizure can be associated with a non-epilepsy attack. So things like short pauses in movements or a waxing and waning tempo of the thrashing motion. And along with that, previously, I think one of us has said that seizures are due to a sort of a synchronous discharge of the neurons in the brain. And that results in almost symmetrical tonic-clonic motions in a status epilepticus patient. If you see asynchronous movements, then that's really strongly associated with the non-epileptic attacks. And another strong indicator is something that I think Simon probably pulled out of the bag last night, which is pelvic thrusting.
We're talking about on the dance floor, yeah?
We are, yeah. Well, Bristol was being torn up by Dr. Simon Lang with his pelvic thrusting. If anyone was watching, they would have thought that was a strong indicator for a non-epileptic attack. Because
put him in a safe place, tell him everything's going to be fine and you're not going to hurt him. Is my take home from that. Okay.
Exactly. I'm glad you've been listening. And that's important because pelvic thrusting apparently is almost non-existent in status epilepticus. So that's a real good one to remember. And finally, eyes. So eyes and mouth are often shut in non-epileptic attacks compared with status where they're often open.
I remember reading that a year or two ago, I think, when there was a really awesome episode about non-epileptic seizures on Femcast, wasn't there? And I remember going back to this article and the eyes being shut. It was just, it was an eye-opener, ironically, yeah. But it was because it's just one of those things that actually you don't think of, but it does make perfect sense. And it's a useful thing to be asking people, with their eyes open, with their eyes closed. And for witnesses to that event, it's something that they often remember very well. So yeah, phenomenal. But that's really useful in terms of take-home messages there, isn't it? Or things that will give us some guidance.
Yeah, I think so. And I do have to just give a little shout out because I was sort of put onto these two papers, which have been really nicely summarised on the medical blog site, The Breach, which I hadn't come across before. But if you want to go and have a look at that, those two papers are on there, which was great. So I guess in summary then, it is difficult to differentiate between the two conditions, but it should remind us that we should be not only taking sort of our classic observations from these patients, and we're going to talk about management in a second, but actually recording the characteristics of a convulsion and actually taking time to observe what you're seeing is actually really important. And I guess the final bit is that there's actually a lot of evidence that the overwhelming majority of these patients with the non-epileptic attacks can recall a lot of events from during the episode. So I will reinforce the message to be kind to them and not be nasty. But I do have one little question, I suppose, to throw out to the floor, which I think I know the answer to. But what about if you still remain in doubt? So you're not sure whether this is a non-epileptic attack. Is it stated as non-epileptic? Not really sure. Does it represent a sort of a greater danger to the patient to fail to treat someone in status than it does to give the first-line antiepileptics and the potential side effects to someone with a non-epileptic attack disorder? I don't know. I think I know my answer, but what do you reckon?
I'll put my hand up and I'll go first. So I think it's absolutely more dangerous to not treat someone that you consider might be having status epilepticus. I think that if you look at the side effect profile of the drugs that we're giving, which will be later on, particularly as first line agents, then I think that for someone that is medically trained, we'll be able to support that patient through those side effects in the vast majority of cases, and actually to potentially prevent the mortality and morbidity associated with status is definitely worthwhile. So if in doubt, I would treat personally.
Yeah, that was kind of my thoughts as well, is that the side effects of the first line agents are inherently kind of manageable by the people that are able to give those first line agents. So yeah, I'm kind of on board with that idea as well, I think.
Okay, well, we started to talk a little bit about what we're going to do with these patients. So let's have a think in more detail on exactly how we're going to assess these patients and deal with them, starting off pre-hospital and then working into the in-hospital environment. So there are two main goals with these patients. Firstly, we want to prevent any secondary brain injury whilst they're seizing and to maintain cerebral perfusion pressure. And also, at the right point, we want to be terminating seizures if they look like they're not going to self-terminate within the first few minutes. And these actually can be quite overwhelming patients to be confronted with, because your normal A to E approach almost seems completely disabled by the fact that you've got a patient that is shaking violently in front of you, and the way that you'd normally get your hands on that patient can be quite difficult. So we've got to make sure that we do the basics really well, we're not distracted, and by ensuring the fact that not only are we safe when we're dealing with that patient that's moving in quite a violent manner, but also that the patient is, and that anything that they can potentially damage themselves against is cleared from the scene. So once we've done that, we're then going to go on to that A to E assessment. So as we've already mentioned with the airway, there can be a pooling of loads of upper airway secretions. So just simple things like suctioning around the mouth, getting their airway into a decent position, use of airway adjuncts can be really important, because there can be a lot of obstruction with these patients. There can also be trismus, but actually breaking that is going to come with the medications that we'll come on to discuss in a minute. We want to be ensuring with this altered respiratory pattern that we're providing them with high flow oxygen and making sure that they're getting as much oxygen on board as possible.
I think you're right there, Simon, and breathing's one of the most challenging issues, isn't it? Like you say, when they're moving around and thrashing about so violently, actually assessing any adequacy of ventilation is really challenging. I mean, you can think about putting in nasal end tidal if you've got it available. You can maybe try putting a SATS probe on, but I think you have to accept that these things are probably just going to come off. And actually, we have to work almost on a worst case scenario. We know, like you say, that status epilepticus can interrupt your respiratory pattern. So we need to get oxygen on at 15 litres a minute early doors, and that is supported by the British Thoracic Society and GRCalc, both of whom say that that is absolutely appropriate. They do go on to say that once you can accurately measure the peripheral saturations, that we should then start targeting the oxygen to 94 to 98%, but realistically that's not going to be until they reach the postictal phase, I don't think.
No, and I think the assumption is, isn't it, that respiration is inadequate, and that for that patient to have the best possible outcome, we need to make sure that that respiratory pattern is not carrying on for a long period of time, and that we're going to be terminating it again after the first few minutes. And if that patient's still seizing in front of us, the C assessment is going to be really difficult as well. It's going to be near on impossible to be able to feel what their pulse rate's doing, to assess something like cap refill, to get a blood pressure. So it almost becomes a redundant part of your assessment. When it comes on to D, well, you are going to be paying really close attention to what exactly is happening, whether or not the symmetry of the movements is equal, the sort of tone that you've got, whether or not they've got central reflexes that are present, which wouldn't fit with it being a convulsive status epilepticus. You're going to have concurrent activity as well, checking the blood sugar, and when it comes on to E, you're going to expose them. You're going to be looking for things like rashes, things that might give clues of infection, and you're going to be getting a temperature as well to see whether or not this could be one of those hyperthermia-related seizures.
So I guess now we need to start thinking about the fact that if this patient is still seizing, the fit has been going on now for more than 5 minutes, we need to start thinking about terminating this seizure, and that means some pharmacotherapy. So when we're thinking about medicines for status epilepticus, they can be segregated into 3, sometimes 4 different categories, and that is first line, second line, and third line. So let's think about the first line. Seems like a pretty sensible place to start.
No, I want to go in at the third, mate. I want to go in at the third.
You're so radical, Rob. So the first line approach for any setting, I believe, pre-hospital, in hospital, or anywhere, is very, very consistently benzodiazepines. And that's because they are relatively safe and they're very easy to administer. They're quite lipophilic, so you can put them in, you can do buccal, you can do PR, intramuscular, IV, IO, pretty much anywhere you fancy, really, and the benzo will work. So that's the types of benzos that you might come across are diazepam, midazolam, and lorazepam. And we're going to go on and talk about those different agents in a second. I just want to really focus on the benzo as an entity and a whole at the moment. So why do we use benzos? Well, they work at GABA A receptors in the brain. And they work by binding to a modulatory site on that GABA receptor. And that changes the shape of the receptor to increase its affinity for GABA. Now, that's a useful thing because GABA is an inhibitory neurotransmitter. So effectively, the benzodiazepines enhance the effect of these inhibitory neurotransmitters and create this nice depressant, sedating effect in the brain. Why is that? Well, when GABA binds to these GABA receptors, it causes an opening of a chloride channel. The chloride flows down into the cell, causes hyperpolarization, and then that decreases the excitability of the cell. So this is all good. But the interesting thing around benzos is that some studies recently have shown that the effectiveness of them decreases rapidly from the start of the seizure and progressing through it. And there was a paper back in JAMA Neurology in 2018, and that found that in paediatric patients with status, those who received the first-line benzodiazepine treatment more than 10 minutes from the start of their seizure had higher odds of death, a higher odds of receiving continuous infusion of third and fourth-line agents, and had longer convulsive seizure duration. All these things are not good. So why does this happen? Well, really interestingly, two papers that came out in 2005 identified a potential mechanism for this that seems to have been pretty much adopted. And they both independently found out that GABA receptors seem to internalize and decrease their density in the synapses in the brain with longer seizures and the longer duration of seizures. So that's really fascinating. So the internalization of those receptors means that there's a reduced response to GABA.
Getting all excited about your physiology again?
I don't think it is. I think it's his pharmacology. He's doing his non-medical prescribing, clearly, I reckon.
No, I love it. But it gets even more exciting because not only are GABA receptors internalized, meaning that your benzos don't work as well, but actually at the same time, NMDA receptors appear to accumulate in the synapse due to relocation from inside the cell. And so that's really interesting because glutamate binds to NMDA receptors, and that's an excitatory neurotransmitter. So that seems really contradictory to what we'd really want to happen. But it does make us consider the fact that maybe ketamine might be a useful agent because that works at NMDA receptors to block the action of glutamate. But sadly, although there have been a few studies around it, there was a systematic review in 2018 that really concluded that actually we couldn't yet draw any firm conclusions. And I guess leading on from that, there's been a small number of animal studies and a couple of human ones that have looked at early polypharmacy, so things like giving ketamine and benzos at the same time. But again, really sort of inconclusive findings sort of at this point in time.
So in summary, just to bring it back, there's been a lot of GABA rays flying about there over the last couple of minutes. But yeah. So just for my simple mind, so GABA is good because it's an inhibitory neurotransmitter, and benzos enhance the effect of GABA. So therefore, they've got to be a good idea too. Yeah.
Absolutely. And the effect of the benzos decreases with time, which I think then obviously really nicely ties in to the fact that we've decreased our definition of status from 30 minutes down to 5. So get the medicines in early on.
Yeah, agree.
So like I said, though, in the chat there are different types of benzo, and I guess that raises the question as to, you know, which is the best? Is there a better one to be using? So worth thinking about that, I think.
Oh, is that me?
Yes, it is, Simon.
Excellent.
Wakey.
Right, well, fortunately, there was a Cochrane review in 2014 which had a look at which of these benzos was going to be best. I think before we run through it, it's fair to say that the summaries from this are pretty long, and it involves almost some conflicting information. But stick with us, and we will run through it, and we'll see what this means for our practice, because the evidence base on this area is pretty tricky. So diazepam, you will be really glad to hear, is better than placebo for stopping seizures.
Well, that is good news.
That is, yeah, it's justifying your practice. Lorazepam was better than placebo for cessation of seizures, so that's great too.
Oh, good.
Lorazepam's better than diazepam for cessation of seizures and has got a lower risk for continuation of status epilepticus, requiring a different drug or general anaesthesia. Lorazepam's better than phenytoin for cessation of seizures. And for pre-hospital treatment, midazolam IM was as effective and probably better than lorazepam IV for cessation of seizures. But in general, there tends to be the response of somewhere about 50 to 60% that a benzo is going to stop seizures when compared with placebo. So it is quite effective in doing it, but it is by no means a golden bullet when it comes to stopping seizures. And I think we can get quite tied up on which benzo we're going to be giving. But to be completely honest, I think getting them in a timely fashion with whatever is available in your service is the thing that is most important to be doing. So if that list wasn't long enough for you, there's another list that you can go and have a look at as well. For the things that they came up with, there's no definitive conclusions, but some statistically non-significant trends. But you'll be glad to know that we're not going to run through them. But the sorts of things in that Cochrane review that they were talking about is the trends to do with the effect on respiratory drive and the need for ventilatory support with these different drugs. So again, go and have a look at them. There are no hard and fast absolutes with them, but there are some information that you might want to bring into your practice a bit.
So talking of hard and fast guidelines then, let's think about what UK ambulance practitioners are going to be doing when they're on scene with these fitting patients according to JR Calc. So interestingly, the sort of start of the termination of seizures section says that if the patient's got their own buccal midazolam immediately to hand, then you should administer that first before attempting IV access and instead of PR diazepam. Now, I guess you could look into that and we could argue the what's and the wherefores for that one, but actually I think it probably makes sense. It's very rapid acting. It's an easy area of the body to get to. So I think this makes sense. So buccal midazolam, if you've got it, use that early doors. You're empowered to do that as a UK ambulance clinician. But if there is no midazolam available and you think IV access is likely to be challenging, then PR diazepam seems to be the most sensible way to go. I think all the time when we're thinking about these different absorption routes and the different routes for administration, we need to think about the overall kind of plasma concentration of the drug, don't we? So PR diazepam is very rapid to give, but takes a lot longer to get into the circulation, as opposed to IV access, which is sort of instant plasma concentration, but might take you longer to get IV access. So I think really you need a pragmatic decision as to basically, like Simon said, what is the quickest way to get your benzo into the patient. It doesn't really matter which benzo or route you choose, but the combination needs to be the fastest. And I think that's probably the best way to see it, really. But if we've given that first dose, whether that's buccal, PR or IV, if the seizures don't stop after 10 minutes, then we can give a second dose after the first. Now, ideally, that will be IV. And I've certainly seen quite frequently if drugs are given PR and then the second dose is IV, it's very often you do see a termination of seizures. So I'd really reinforce that point. I think the challenge comes for UK paramedics is that if the patient is still fitting after the second dose of benzo, I think you're in a bit of a tight spot. The JR Calc guidelines say that you should seek senior advice for a third dose of benzo, but only if you're 15 minutes from hospital. So that means they would have been fitting for a total of sort of 25 minutes almost.
Plus the call time, I guess, as well. So you could be talking even longer than that, couldn't you?
Well, exactly. Given the fact that we now know that potentially these GABA receptors are boosting themselves inside the axons and not being available for benzos to work at, I'm not totally convinced by that approach. And you've also then, got the issue of quite a big dose of benzo. And is that going to be associated with more episodes of respiratory depression? I did try to look into that and I couldn't find the answer. But I think it's definitely something you need to think about. Other things to think about if your patient is still fitting after 2 doses is, could this be the non-epileptic seizure? And just remember to step back and look at exactly what you're seeing and how that seizure is presenting. And also just think about poor absorption or poor administration. Is your IV actually in? Has it blown? Did you put the PR tube all the way in up to the black line and so on? And I suppose that just leaves us to wonder what happens if we don't give that third dose, or if you haven't got a senior clinician available. Do you transport immediately after the second dose while they're still fitting? That's challenging. I've definitely had situations when I've tried to get fitting patients down the stairs on a carry chair, and it is not fun and it's not safe for anyone. But sometimes, our hands are really forced, isn't it? And I don't think there is a nice, clean answer to that.
You won't find a guideline for that, will you?
No, not at all. Not at all. So anyway, that is JR Calc in a nutshell. It is effectively 2 doses of a benzo, potentially a third, and 10 minutes between doses. So yeah, and then we're a bit stuck really. So that's the first line and the second and the third and the fourth pre-hospital. So what happens when you've got more options?
things are, as you say, with regard to the first line things are very, very similar in hospital. But I think for me, working in hospital, my preparation for these cases starts as soon as I get a pre-alert. So if I know that I've got a patient that's going to be arriving who's in status or might be in status or has been in status, my approach to that is quite different. So essentially what I want to do is, I'm aware of all the evidence surrounding the importance of first line medications, but the early administration of second-line medications is key, and what you need to be prepared for is that as that patient gets wheeled through the door, that may well need to start running almost within a minute or so of them arriving if that ambulance crew of paramedics have administered 2 really good doses of benzodiazepines. So you need to brief your team to let them know essentially what the plan's going to be. So it's going to be an early second-line medication if they haven't had a decent go at first-line treatment to begin with. But coming back to that, so with regard to those first-line medications, I think there are some situations whereby if you've got a short run time, or if that patient might not have had, say, for instance, a definite administration of that medication. So, if it's been buccal and it's been given by a carer, has it poured out rather than been absorbed into oral mucosa, it would probably be worth giving a dose of benzodiazepines. And you want to give the best dose you can give as early as you can give. So for me, we typically use lorazepam in hospital because of its longer half-life and less likely recurrence of status. So it's generally lorazepam at 0.1 milligrams per kilogram for children, but for adult doses it's essentially 4 milligrams from the offset. And if the patient has a seizure in hospital, that'll be what we'll give as the second line as well. Now, just coming back to when you were talking about managing the effects of sort of multiple benzodiazepines, there was one paper with regard to lorazepam dosing at 0.1 milligram per kilogram and 0.2 milligram per kilogram. So these patients were getting either 8 or 16 milligrams as their first line treatment, and actually the incidence of respiratory depression was no different in either of those groups. So don't be too worried, but obviously you need to know how to manage it if that occurs. So once we've checked that those 2 doses of that first-line medication, so those benzodiazepines, have been reliably given or reliably administered, it's really on to our second-line anti-epileptic. And there are a number of those that are discussed in the literature. So there was a good meta-analysis from 2019 which looked at the efficacy and cost-effectiveness of second-line anti-epileptics. And the ones that the ones that we're likely to have heard of or certainly have in use in the UK are phenytoin, phenobarbital, sodium valproate and levetiracetam, or Keppra. And essentially what they found was that the chance of stopping the seizure, so the chance of seizure cessation for those drugs, was phenytoin was 53%, phenobarbital was 80%, sodium valproate was 71%, and Keppra, or levetiracetam, was 62%. So if you remember when we talked about the 60% chance of cessation with the benzodiazepines, you then add a second-line agent in, such as phenytoin, and there's then a further 50% chance on top of that being effective, if that makes sense. So these second-line agents are potentially effective, but again, you need to be aware that things might progress, and if we know that 30-minute window is, absolutely crucial, you need to be in hospital on the ball with regard to the next steps that are going to be coming. So what is it that actually NICE say? So NICE are pretty clear in their guidance. So they say for established status, the medication to be administered is phenytoin. So phenytoin, the loading dose for that is 20 milligrams per kilogram. So typically in an adult, we'll give a 1 gram loading dose. However, this is a pretty problematic medication. We've discussed it on a Papers of the Month not too long ago, and it can be associated with some adverse features, so cardiovascular effects such as arrhythmias and hypotension, which can be pretty profound. But also, if you have a patient that's seizing and that cannula becomes displaced, one of the big concerns around it is extravasation necrosis, so you can get necrotic skin from that phenytoin leaking within it. Now, the systematic review in 2019, and there was another one before that in 2016, found that most of those adverse events were occurring when you administered it at more than 50 milligrams per minute. So for that 1 gram loading dose, to get rid of those or reduce the chances of the adverse events, you need to give it over 20 minutes. So this is why I'm saying that when you're thinking about your second line agents, you almost need to have it up and running the second that patient gets wheeled through the door if they've had a good dose, because it's going to be 20 minutes before the full dose has been administered to them. The other problem, of course, with phenytoin is that when you draw it up, it develops precipitates, and so you need to use a PAL filter or a 0.2 micron filter to stop those being injected into the bloodstream. So from an administration, a drawing up, and a sort of safety and efficacy point of view, it is quite a difficult drug, actually.
And just to recap on the sort of timescale we're looking at here, if you're following it to the letter, so we were talking about 5 minutes of seeing whether or not that seizure was self-terminating, giving a benzo, waiting 10 more minutes, giving another benzo, waiting 10 more minutes, then giving phenytoin over 20 minutes. So in a really slick setup, we're looking at a best case scenario of getting through the phenytoin and seeing whether or not that seizure is stopped within 45 minutes, which is a long, long time. And that is really important when you consider what the next step, which is going to be an anaesthetic.
And that is why it is so crucial that, you can't have 20 minutes of twiddling your thumbs, scratching your head. When this patient gets alerted, you need to know that they're going to need a second-line med given almost instantly, because the pre-hospital system is so good in the UK that they're bound to have had their first-line medication given and administered the best they possibly can. The other medication that is worth mentioning, though, is Keppra or levetiracetam, which is not mentioned in the NICE guidance. But that NICE guidance was written, I think, in 2004, but it was updated earlier this year. But it was before two pretty big paediatric RCTs were published. Now, Keppra is pretty decent because it can be given over 5 minutes. So it can be given as a slow bolus over 5 minutes or in a bag. And that therefore obviously gives it the additional 15-minute time benefit over what phenytoin would have in terms of its safety profile. It's more compatible with IV fluids, and it's got less interactions and risk of adverse events. So overall, I think most of the neurologists that are out there nowadays are recommending that levetiracetam or Keppra is the second-line drug of choice for epilepsy.
Because of those benefits, we've started carrying Keppra pre-hospitally as part of the critical care team. We, previously didn't have a second line, mostly because of the complexities that you've described around how you give phenytoin. But Keppra is just far simpler to administer and requires kind of less thought, I suppose, around how you're giving it.
Yeah, I think so. And talk to our nursing colleagues, in hospital, it's not a big deal necessarily to give the phenytoin, but it's just that it naturally takes a couple of minutes to draw up. It naturally takes a couple of minutes to get onto a pump, and it naturally takes a couple of minutes to get it checked and all the rest of it. So actually all of that adds to that 20 minutes. Whereas with Keppra, you just have that additional benefit of it not requiring that level. So I think it's just probably a better choice as a emergency drug. I mean, if you have a patient who, goes into status on a neuro ICU, then actually, if you've got phenytoin there to hand and you've got all that can be given straight away, then there's no problems from my perspective. But, it's just from an emergency care point of view, I think Keppra has its benefits.
Yep.
And those papers, Concept and Eclipse, as you mentioned, they were paediatric RCTs, but obviously people have extrapolated stuff from paediatric practice to adults. We're not referring in this podcast to the guideline for paediatric status, but it's got essentially the same sort of timescales and medication that is advised to be used, but with the consideration of paraldehyde.
Absolutely. And just a brief recap on the Concept and Eclipse trials. So around 50% of both groups, so the Keppra and the phenytoin, had seizure cessation at 2 hours and didn't require any further medications. But the complication rates between the two were pretty low generally, but there wasn't any documented benefit to Keppra. But as I said, it really comes down to the ease of administration, which is the key factor, and the timeliness of administration that lends itself to probably being a better, in my mind at least, second-line agent.
So I think that's a really nice summary of the second-line agents. And just before we jump on to third-line treatments, which is effectively anaesthesia, it's worth just thinking back to one of the other causes of seizures that we mentioned earlier on, which is eclampsia. Because eclamptic fits are really unusual and a bit of a unique case. And like we said at the beginning, no one really quite understands the mechanisms behind why eclampsia creates the signs and symptoms and the seizures that it does. But what we need to know is that benzodiazepines are effectively useless when trying to manage seizures in the face of eclampsia. And actually what these patients need is magnesium. And in these cases of eclamptic seizures, they get 4 grams of magnesium as their initial starting point.
So as we've alluded to then, anaesthetic is going to be the treatment for those refractory status epilepticus that hasn't responded to all of the things that we've given before. Now, also, as we've mentioned, the timescale that we're talking about is actually quite prolonged, and we're talking about going well over this 30-minute mark when we know patients can really suffer morbidity and mortality. And I think it's worth thinking, as soon as you know that you've got this patient that isn't responding to their first benzo, that actually we might be going down this route. So preparing for this early is a positive thing to do, and there will be clinicians and practice out there that looks to give this anaesthetic before possibly all of the second line antiepileptic has actually gone in or had a chance to work. So when looking at the patient, there are going to be certain characteristics that we've got to be really aware of when we're trying to assess from an airway perspective. So actually things like mouth opening, having a chance to really go back into the history to find out whether there have been any previous anaesthetic problems is going to be really taxing. But we know that there are going to be certain things like an airway obstruction. They might have trismus before we're putting them off to sleep. Really getting them well loaded with oxygen prior to delivering the anaesthetic is quite challenging. So you've got to go about doing that the best way that you possibly can, with use of adjuncts, trying to position in a relatively good manner, getting good access, and we also know that their cardiovascular status may be pretty depleted by this point, and patients can be hypotensive, and going on to give them an anaesthetic can result in further morbidity and mortality associated with that. Now, it's pretty much thought that if you give enough anaesthetic, then you can stop that seizure from occurring. So this is going to be a really good treatment. But what anaesthetic to use and what muscle relaxant to use is again something that we might think about. And the good news is that we can tailor that to our patients. So traditionally, midazolam would have been the induction agent of choice at a loading dose of 0.2 milligrams per kilogram. Now, this is a GABA agonist, and James has already gone on about how useful that is to know about. It's got a half-life of 2 to 7 hours, but we also need to be aware that phenytoin and phenobarbital lower midazolam concentrations. And the thing that we need to also be aware of is that we can get adverse reaction from hypotension and respiratory depression. Propofol is a practical alternative and is really fast in onset and has rapid clearance. Again, a loading dose of about 1 to 2 milligrams per kilogram as a ballpark figure to think about. Again, it's a GABA agonist and it's got some NMDA antagonistic properties as well. And its half-life is around 30 minutes up to 7 hours. But again, you've got to be aware of that hypotension and respiratory depression. Ketamine, not traditionally thought of as a great induction agent for status, has actually got some theoretical use in this area. And as we've said, the evidence base surrounding these different agents is not that solid. So we're just going off theoretical and experiential practice. Again, a bit of a variation in the dosage that we're going to be using, but again, around the 1 to 2 milligram per kilogram. It's an NMDA antagonist and a half-life of 2.5 hours. Phenytoin and phenobarbital again are going to lower ketamine concentrations, but the different side effects might be of some use in your patients. So actually with hypertension, but beware of the hypersalivation. Some countries will have removed this from their formularies already, but thiopentane is there in the NICE guidance as well as the induction agent of choice when that was written a few years ago. There are different risks and benefits associated with all of these induction agents, and you've got to pick the right agent for your patient. Finally, when we're thinking about that paralysis, what we're going to be looking at in our patients who have had an RSI is trying to see whether or not that status is continuing. So having them paralysed takes away that ability to watch the clonic activity and the muscle spasm that's ongoing. There will be some debate whether or not you want to use suxamethonium or rocuronium, but be aware that if you use rocuronium, that's going to last for a long period of time. It might get you some better intubating conditions, but it's going to mean you're not going to be able to see those physical clues to still being in status. So things like EEGs, if you can get your hands on them, are going to be really useful.
So we've already talked about the importance of doing sort of concurrent actions really with these patients. So, investigations, but also the management of the actual seizures themselves. However, one of the things that we need to consider is what actual investigations we're going to do once we've got control of that patient and cessation of that seizure. So we need to be thinking about bloods. So some of the pertinent things that we should be looking at are certainly the blood gases, the blood sugar that we'll have picked up earlier. We'll be sending off bloods for renal and liver function just to check if there's any issues with regard regarding to clearance of their epileptic medications, etc., etc. Their electrolytes will be of importance, and particularly the calcium and magnesium on top of the general ones that we send. A full blood count should be sent to check for platelets, a clotting screen, and also, crucially, if they're on any anti-epileptic drugs, so phenytoin, etc., sodium valproate, we could send drug levels to see actually what they currently are for that patient. The other things that are worth considering are whether or not there's likely to be any benefit to doing any toxicology screening, although that's not something that is commonplace within UK practice. Moving on from that, the other investigations from a radiology perspective, well, I mean, most of these patients will end up, particularly if they're on the second line or third line treatment, will need to have a chest x-ray to evaluate potential aspirations. And the final bit, I guess, is around when to CT and when to do lumbar punctures. And I think you need to probably have a read through the NICE guidance to look at what their specific indications are. But certainly for your known epileptics that have had seizures, the threshold to do a CT is probably much higher than your first presenter who you're unsure of the exact etiology of why they're seizing in the first place, is probably a good summary.
So dragging it back to those that aren't on a ventilator and you are going to be able to potentially discharge from your emergency department, what are the sort of things that you need to be thinking about? Well, fortunately for you, you're not going to have to listen to them all, because there is a fantastic leaflet that you can download from the NICE website on all the information that you need to be giving to your patients. But you need to be giving them advice regarding driving and the restrictions that come about for patients having had a seizure. And those, again, are there online from the DVLA to go and have a look at. But these patients are probably going to need to be followed up if they're not already in the right system. And most departments and systems will have a first fit clinic, which you can refer to.
Yeah, and that's a very good point, and that is exactly, it will be dependent on local factors, but your first fit clinic is the thing that you need to know about and how it works. With regard to NICE, they say that it should be essentially that the patient is seen within 2 weeks by a neurologist. One of the things that I think is really, really important for you to try and stress to that person and their relative is that if you can get the person who was there at the time when their seizure first came on to go with them to that neurology appointment, it is such gold in terms of information, because thinking back to those patients that are misdiagnosed, a lot of that comes from secondhand information, I suspect. So actually, if you can get that person who was there at the time to maybe make some notes on the day that it's happened about what they looked like, what happened, what were the events surrounding it, and then take them with them to the neurologist so that they can ask all them questions and get the responses, I just think we're going to do better for our patients and hopefully reduce some of the misdiagnosis.
And actually, the benefit with everyone having smartphones, if a member of the family or close person to that patient has got a clip of video of what actually happened during that seizure, providing they can give some safe first aid and having cleared the scene of any dangerous objects, that is really valuable, isn't it?
Yeah, yep.
Because I think when you look at first fit clinics, actually only about 50% of patients are eventually diagnosed with that having been a seizure. So there are a multitude of other things that those clinicians in those clinics will be thinking about. So that is it. You'll be delighted to hear. So, just running through things again. Seizures are a common presentation to emergency care services. They carry with them a high rate of morbidity and mortality, and there are a multitude of reasons, not just epilepsy, why patients will seize. And knowing those and thinking about them concurrently with the management of that seizure is really important to ensure the best outcomes from our patients. Again, there are a number of categories of seizures, from focal to generalised, reflecting the areas in the brain that are affected. And when you've got that patient in front of you that's seizing, it's really important to try and evaluate how that episode is affecting their neurology, the symmetry of it, the loss of reflexes, how quickly they're regaining consciousness is really important. There are a number of investigations laid out in the NICE guidance as to what we're going to do when someone's got a seizure. Simple things first though, we need to have a look at their blood glucose, we need to have a look at their temperature, and we need to be having a look for signs of things like meningitis on those patients that are seizing. Most seizures are going to self-terminate within the first couple of minutes, but if they don't, and if you get up to around 5 minutes, then actually they're probably going to need some intervention. First line is probably going to be benzodiazepines. A multitude of flavours are available, and go with the one that your service is supplying. You're then going to be thinking about another benzo. Then, if those are failing, onto a secondary anti-epileptic drug. And then, if that's failing, onto thinking about an anaesthetic and the different choice of agents that can be used. There are inherent problems with those patients that are going to be getting anaesthetics, and that relates to how well we can oxygenate and ventilate them prior to their RSI and whether or not they're in a state of cardiovascular compromise at that point. Once we've got control of their seizure and we're happy that they're in a safe place and back to a neurologically normal place, we've identified any underlying causes, we've investigated and treated them for that appropriately, then we're going to be thinking about discharging them. Make sure you use your local services appropriately, and do make sure that you document and give that patient appropriate discharge advice. That is it for this episode of Roadside to Resus. We're going to be back with really regular Roadside to Resuses and our Papers of the Month for you in 2020. A big thanks to SJ Trem for collaborating with us on this podcast and enabling us to deliver this to you. So take care of yourselves, and we will speak to you soon.